My doctor is
How are you? Where is your tummy pain? The patient is like, here. Some people are not great communicators. A huge amount of radiation, and we're already getting radiated from everywhere. The cancer started.
Kia ora.
Kia ora.
Welcome to NOIS.
NOIS.
No one is safe.
And no topic is safe. So we're going to try and make today's topic quite safe.
Quite safe.
Yeah, we're going to be safer by the end of it, hopefully.
Yes, so first of all, just want to say a huge thank you to Tui Medical.
Thank you guys
your
representing
local doctors and the Waikato www.tuimedical.co.nz.
Yes.
Various clinics around the
yes, we have tollbacks for your hearing needs.
Some dental.
Yes, there's Tui Dental as well. Quite a few branches throughout Aotearoa. And we also have Tui pharmacies as well. So we're quite the collective.
Pharmacy.
Yes, we're quite the collective. So please do drop in. Newly as well is the Tui Allied Health as well. We should always remember to shout out to them. So if you want your many, you want some physio, OT services, we have this available at affordable prices. Also covered under ACC.
Oh, look at that.
Yes.
Thank you, ACC. That's lovely. I'm just going to kick straight into it.
Yes.
So you'll get the gist of today's topic quite quickly, I'm sure. So I've got a question for you, Tonya. So obviously Tonya is a doctor, as you well know. My doctor never listens to me.
Oh gosh. Well, isn't this...
What do you take from that?
Oh, I mean, that's a very, very common complaint. And I think a lot of times interactions between doctors and patients is a two-way street, which I think a lot of patients may not fully understand that. Again, different doctors are different, and they're human beings with different qualities. And just like in any other relationship, this is a sort of relationship.
Totally.
Quite a quickly formed one. Generally within 15 minutes you should be able to build this rapport, depending on kind of individual. Some people are not great communicators, both as doctors and as patients. So the same way in a lot of relationships that I know of, they find that the man is not listening properly, or she's articulating something and he's not getting it. So
it's always the man.
It's always generally the man, isn't it? And so depending on how your doctor's ability to articulate themselves, which is obviously what makes sometimes a good doctor versus a bad doctor, is that how good are they able to understand what you're saying? How well are you articulating what you're saying, so that they can understand it, hopefully get to an answer for you. The other flip side to that is that obviously, again, you might be good doctor in terms of your knowledge, because there's the information and knowledge aspect, but there's also the social aspect.
If you're a bit awkward.
If you're an awkward human being, all in all, you would probably be an awkward doctor.
So it comes down to the two-way street and the patient being able to articulate what their issue is, what their problem is. If they're not describing their symptoms, their pains, being able to even on the scale.
Is really important because So that's generally the main, I suppose, reason where you may get this conflict of my doctor isn't listening to me. Maybe there is the fact that he maybe isn't listening because
he doesn't understand.
He doesn't understand, what you're trying to say, or maybe he's just tired. But you have to understand that you can't be tired every day, guys. It is what the job is, and it's important that you do, you come in full face. Come in full face, guys. Hopefully
and
that's not me.
Patient as the patient as well.
Love that. You have to also be able to be patient even with your patient, because they are sick. Human beings are already kind of difficult sometimes to interact with on a good day. So when somebody's really unwell, you're obviously not your best form, so you're probably not going to articulate yourself as well. So doctors need to be patient.
But the patient needs to be patient.
The patient actually needs to exercise their role here, which is patience.
Is that why they're called patients?
I wonder. Because they need to be
patient.
Well, I'll tell you what, a lot of them are not patient, that's for sure.
Doctor has misdiagnosed me.
I think the really crux of the matter is just like we touched a little bit. It is because a lot of people think that doctors are X-ray machines
Yeah.
or CT scanners, which they are not. Okay. What they want is we're able to collect the information that you give. And from that information, we're able to pull out certain symptoms and signs that fit best with a certain disease or condition.
Yeah.
Now, obviously, that information and the quality, the quantity, the description of how well you can describe that empowers the doctor to be able to find,
to order the right tests.
Exactly.
And
so like you said,
touch the right spot.
Yeah. So I'll give you two different scenarios. Is the patient who comes in with, I have tummy pain. I'm like, okay, so where is your tummy pain? The patient is like, here. I'm like, okay, so that's quite a general area. Okay, let's park that. What would you say the pain is out of 10? It's like a 20. Okay, well, I mean, you're sitting comfortably.
Yeah.
So it's probably not that, but okay, look, like, get it. Clearly, I'm just going to see you're in a lot of pain.
Yeah.
What you're saying, but it doesn't look it. So that's part that. When did it start? Maybe like 6 months. It's on and off. So like maybe I'd say, okay, good. So it's been going on for a while. Does it come and go? Is it every day?
Is there anything specific that triggers it? Or?
No, it just comes, it just goes, it just comes. Yeah, I'm not like, it just does something, I don't know.
So it's very vague.
Yeah, very vague. So somebody comes in, I have tummy pain. It's literally right here in the right lower corner of my tummy. It comes after I eat. It usually lasts. The pain is usually like, it can be a 3 out of 10, but sometimes it can go all the way up to a 6 out of 10. Is there anything you notice around time? Well, I have noticed that maybe sometimes it's my periods around that time, but I don't know if that has anything to do with it. I'm like, that's okay. That's the more you can tell me, the better.
The better.
Now, those two different kinds of patients it's going to be very easy for me now, because now I have, unless I send targeted questions at them, I have a direction in which I'm going.
Yeah.
Because I'm saying, okay, this is probably more reproductive, but I'm not ruling anything out, but reproductive is going to be at the top of my list. So when I'm requesting further tests, I know what I'm going to prioritize. Yeah. Because over ordering is just as bad as under ordering tests, which people don't get. So those two types of scenarios can occur. And that's where a misdiagnosis might come from. Of course, everybody is different. Every human being is different. Some people may have weird symptoms, depending on the race, depending on how well they are able to
overall health
health and stuff. So that's generally, broadly speaking.
Do you think though that it's more common, bigger, scarier diseases where something may have been missed?
Yeah, I think it can, but I think what a lot of people may not get is that, or understand, is that more than one thing can exist simultaneously.
Yes, true.
So you may be having
Don't forget,
okay? You may be having a tummy ache, yes, which just be your IBS. But at the same time, it could be that, and at the same time, you could have quite a silent tumor there, which is completely unrelated. Yeah. It's sitting in another part of your abdomen, which is huge, and you have IBS, and you've just, because of your symptoms of diarrhea after you eat certain foods, I'm not going to say, oh, let's get you a CT scan of your stomach because you have diarrhea when you eat onions. Stop eating onions. However, if you're ongoing and you're persistent, so people they go and get a second opinion. They're like, it's been going on for ages still, and in that scenario, I do always say, if my patient represents with an ongoing complaint, I tend to escalate my management. Yeah. I tend to now do something else, just again to ease their mind, because that's just a part of patient care. It's not just actually giving medicine and treating them. You want them to be less anxious. Like overall helps them. They go and get this personal scan and see that there is a tumor there in like their kidney, which is in your abdomen, but clearly it has nothing to do with this. But they're like, oh, you see.
But sometimes the pain can travel, right? So it could be.
You can get referred pain, but referred pain always travels in its own pathway. So different organs are linked to different parts depending on how they're formed when you're an embryo. Because some things start in one part and move to another part. So, for example, your testicles, for every kid is started off as a girl. So your ovaries are before your genes say before your chromosomes say this is a boy or a girl. Yeah. Everybody's a girl. Yeah. And then it says it's a boy, and then your testicles your ovaries change to testes and travel down and out. So that's why when you kick a guy in the balls, they feel it in their stomach. Because they're like, because that's the referred pain of the path of where it originated from.
Yeah.
So you feel it in your ovaries. That area is where a boy would feel it. Things like that. So that's usually where the referral of pain is. So kidney pain would not be from there, it'd be in your back. The patient may not know that. They'd be like, oh, misdiagnosed me. If you just sent me to the CT scan, I'll probably be fine now. My tumor is like, probably not.
Yeah.
But if you scan yourself every day for the rest of your life, you probably will find things.
Yeah, I want to scan myself every day.
But people also have to realize that these scans are radiation. The scans themselves.
What was the stats?
So one CT scan is the 5,000 X-rays.
5,000 X-rays.
Equates to 5,000 X-rays.
So that's 5,000 zaps.
Zaps of an X-ray is what you get.
Of radiation per
CT.
Wow.
So again, people don't realize that these investigations, they are
taking a toll on your body.
Yeah, so you might be scanning yourself to look for the tumor every day, but you don't realize that
you're creating the tumor.
Yeah. The number of those scans you had, you didn't have one, but in the search for one, you created one. So it's just finding that balance, you know.
Interesting. Yeah. Love it. So what are your thoughts on the statement here? So obviously everybody's not for everybody. As you mentioned before, sometimes you don't vibe with somebody, and you probably hear this a lot too, but my doctor is shit. I'm going to change. I want to change.
Thankfully, I don't get that personally. Well, at least I don't say it to my face. But yeah, no, I love the way that even ended because, again, like you said, that was so spot on. Like, you can't vibe with everybody. Again, it's an interaction. If I'm not vibing with you, I'm not just vibing with you.
Yeah, I definitely wouldn't trust you because I'm not vibing. It's like having a good barber.
It's like who does things the way you want.
Who waxes your vag?
You
need to
you want them to be comfortable. Exactly. It's a vulnerable. The more vulnerable a situation, the more you definitely need to vibe with the person. Yeah. If I'm going for a massage or anything that gets any service that I'm requiring, depending on the level of vulnerability I'm going to be put in. Yeah. It would determine the kind of person he may be, or she may be an amazing person or whatever.
Or person, yeah.
But for what I'm doing, or the level of vulnerability I'm in, I would rather maybe somebody else. Like, so some women would come in with vaginal issues, and it is not it wouldn't be abnormal for her to want a female. There is the odd weird scenario where, a guy wants a girl to look at his penile issues. And of course, in that scenario, we have to safeguard, make sure the doctor is comfortable with that.
Yes,
or if a female comes in and says, oh no, I specifically want a male to look at my vaginal problems. It's like, why would a man know more about, why wouldn't you be? So you always have to now start thinking, this might be a little bit funny. Something's a bit off here.
I guess because in urgent care, right, you just get the doctor that's on shift.
But I guess they can request if there is, and if they're super uncomfortable, you can say, okay, do you want a nurse in the room or something like that? But again, it's if your doctor is bad for whatever reason, be it that they just are very impatient, they maybe over-explain in a hard way.
Yeah,
like they give you too many doctor words, which is what they train us to not do. But depending on how many shits the doctor wants to give that day, they may just throw this jargon at you and you feel like you know less than you did before you came into the thing. And you just change the doctor. Thankfully, there's never just one. So you just find one that blends for you.
There may be a shortage, but there's not.
There's not that much of a shortage.
There's not one per town. One per city.
You hope anyways in New Zealand. Maybe down in Gore or in Vicargo, there might be only one doctor in Oban.
Yeah, okay, what about this statement here? So my doctor only gives me antibiotics every time I visit. So obviously antibiotics are good. They kill a lot of things. They cover a very wide
array of things.
An array.
Honestly, this is a safe space, and I really want to educate and empower the patients as much as possible. It is definitely overused.
It can't hurt to have too many antibiotics.
I mean, it can. Oh yes, it can, because you can build resistance. Where antibiotics now don't work when you need them.
Maybe that's what's wrong with me.
But for a lot of times, the patients will not be okay with what we call the watch and wait scenario. Okay, the watch and wait scenario is, I have a symptom today and I show up to the doctor today, and it's not dire, but I've come in and they've paid usually with quite exuberant amounts as the prices of things are going up. I just went to the doctor and he just told me that I should just watch and wait. Like, he's examined me, he's done all these things.
Oh, it's just viral.
Just watch and wait. Quite often the patients are not satisfied with that. He didn't even give me anything. I just went there,
give me an ointment
give
or something.
They want something. So quite often doctors just do that to
make them feel.
Yeah.
My God.
There you go. But a lot of times it's to satisfy the patient. Again, it's what your expectation is. So you always have to figure out what the what's the demand.
Expecting from this visit.
So a lot of doctors be like, what are your expectations today? So I have colleagues who would start or end with, do you have any questions, concerns, or expectations from this meeting? Because a lot of times the patients just keep quiet or they just nod and say, okay. Whereas if they had maybe said, don't I need antibiotics or something? Or don't I need this? Then the doctor can maybe explain it to you why.
Yeah, so
not.
Hang on. So with old Dr. Google in play now, like a lot of, I want to say 9 times out of 10, the patient's coming in to tell you what's wrong with them.
Oh God, I'm gonna love that, don't I?
And they probably already know what medicine they need. And if they're just being told, here's some
and that's it. It's a two-way street. That's the dangerous thing is, yes, you may read Google is very general. It is telling you everything that could be, could not be. It's covering its ass essentially. It hasn't examined you. It hasn't
want a lawsuit.
Exactly. So it just gives you the broad scope of things. So 9 out of 10 times it'll be one of those things. I mean, if you tell me you have tummy ache and I give you 10 possibilities, pretty sure one of them is going to be it. But that doesn't help because I can't treat you for 10 things and hope, the bullseye's in there somewhere. So that is where the clinical practice is. That's where the being a doctor part is trying to decipher who makes it at the top of the list and why I don't want to over-treat my patient because that is in the long run is not good for them. The better isolating the actual problem, the better is the patient. They don't need to take too many medicines. They need to do too many tests and overall they get better. And that is generally the goal. Again, obviously depending on how the patient is. But we do definitely oversubscribe. It's something known in the community to do, especially when it comes to kids.
Oh, really?
Parents, they come in, it's viral. They do not want to hear that.
Pamel.
Yeah. So I say just Pamel and they're like, oh, because the truth is a lot of times these viral things do settle on their own. Sometimes they don't. Sometimes it progresses into a full chest infection. So what I've tried to do to mitigate that for my patients, to give some autonomy to the parents is I give them the script and I educate them that this is viral right now. It could very well change. Here is the prescription and these and these and these conditions would require you giving him the antibiotics. So you can go grab it so that you have peace. Have it put in your cupboard, put it in the fridge if you have mixed it. And if in 2-3 days you see him deteriorating, because you always have to trust that parents, you will never know a child more than the parents because you've seen them for 15 minutes and you can never generalize. So a lot of times parents would know the pattern that their kids generally tend to take.
How they look when they wake up.
When they wake up, this is what happened last time, and then by this day he goes down. So I'm like, okay, good. Now you have the power to do that instead of having to bring him back in, or you're waiting because you're like, oh, I've already paid 200. I don't have to pay another, so amount to bring him in. So they now store this even longer, and the kid is now sicker and they're madder because they're like, oh, she just gave me the antibiotics in the first place. Type thing. So there's ways around these things, but there's generally reasons. It's just how it's explained usually to the patient. So
interesting. So what about why doesn't my doctor just scan me every time I complain? Now we have missed a big problem.
But like we touched on earlier, again, these scans are a huge amount of radiation, and we're already getting radiated from everywhere, our phones, satellite. There's always some form of, so if you can really minimize the amount of radiation you're getting, it's important. The second thing is what I always try to explain to people is all these tests, screenshots of you in that moment. And you can do that scan in that moment, and 5 minutes after that scan, the cancer started. You're not going to scan yourself for another 6 months. You're like, oh, I've had my scan, so I'm happy now. But then
that's something you taught me. I didn't realize.
It's not.
I got blood tests like 2 years before I met you. I was like, no, my LDLs are a bit high, but it's okay because I got a blood test, and you're like, when? I was like, 2019.
I was like, girl, now. Like,
So it's only a snapshot in that moment.
It's a snapshot in that moment. And same thing applies with blood tests as well. It's a snapshot of what your system is doing in that moment.
Yeah.
And that's why there's ranges. And some people sit in the higher end of normal, some people sit in the lower end of normal. You can do a blood test if you're just out of your period and you have heavy periods. I'd expect your blood count to be low. Right after. Does that mean you need a transfusion? Not necessarily, because I know if I repeated that
in a week
or 2 or 3, it's going to be climbing back up to normal because your body should be able to regulate itself.
Yeah.
But because I've captured it in that moment, it is low. So it's unless blood tests that's why they have to have a clinical reason for it. You can't just be doing it for no reason. You have to have a question that you want the blood test to answer, or else you're going to find yourself with more questions than answers. It's like, oh, that was up now. It's like, yeah, well, your liver was off because you had a whole bottle of vodka over the weekend. But they're like, oh, is that? It's like, yeah. Like, is that normal? What does normal mean? Like, your blood test is not normal, but there's a reason for the abnormality. It's different if it was just always high. But if you have a reason, then it's normal then.
Yeah.
That blood test technically is normal. The figures are high. That's a normal reaction to the actions that have been done. Just like somebody saying, oh, I have a black eye. They have a mic. Did somebody punch you? And you're like, yes. I'm like, okay, well then, I'm not saying your eye looks normal, but that makes sense. As opposed to you just coming in and I have a black eye and nothing happened. Then I'm worried because I'm like, oh, why do you
have a bruise around your eye?
Yeah, if nobody hit you.
Yeah.
So yes, the bruise is not normal, but contextually, if there is a cause to it, then I'm not going to worry.
Yeah.
Because that makes it normal. If that makes sense.
So true. Yeah. Okay, what about, so we're talking like big, serious diseases. And okay, so you've been diagnosed with, let's say, the big C.
Yeah.
And the doctor said, look, I'm really sorry, John, but Mary's got...
It's very generic names you have going here.
And of course it's hard to put an actual time on it, But Mary lives for 10 years.
Yeah.
So that would happen often too, right?
Very
often. It's because the doctor's not a fucking fortune teller.
And a lot of times they usually base that severity or aggression of the disease. And generally speaking, even with human psychology, underselling is better than overselling.
Oh, 100%. You don't want to say, oh, Mary's got 10 years in there and she cuts it in 2 months.
This is it.
John's going to be mad.
So if it's like a tumor that I know or a cancer that we know is from evidence and research and other people, and evidence and research is based on the number of people having it and how it has behaved in all these people's cases. I can only say it based on those cases.
Yeah.
I don't know John, or Mary. I don't know when it was caught, how well you're going to respond to treatment. Do you want treatment? Do you want the heaviest treatment? Can you manage the heaviest treatment? Especially knowing what is our goal. Because we know that more often than not, maybe that certain type of cancer is not treatable. So are we trying to buy Mary time? If we're trying to buy her time, Mary being stuck in bed 24 hours of the day because of the treatment of buying her time, what time are we buying her?
Yeah.
If she can't live her life.
Yeah.
So now we're saying let's give her something not as strong. So that means that this is probably going to grow faster, mean that Mary will have a shorter time.
Yeah,
but she would live better.
Yeah, so she'll be able to go and tick off those bucket list things.
Yeah. And then, some cancers respond miraculously well to treatment. We say, okay, maybe it was a 10 centimeter lump. And more often than not, evidence is out there. When they treat it, the lump goes to 8 centimeters for the standard treatment. And then for whatever reason, when they gave Mary that standard treatment, her lump went down to 1 centimeter.
Yeah.
Meaning, even though it's not gone, it means that it would take a whole lot longer for it to get bad again.
Yeah.
So there's always those little nuances that are different for people.
Yeah.
So I think a lot of times that time is just to say, okay, look, this is probably let's be thinking about this. So anything that you want to be able to plan in your life, try and get it all in there if you can. If you get any longer, great. 10 years is usually not quite often, but it does. You do see it happening quite a bit. Yeah, you do see people getting good 5-6 years, which is always great. But you're better to have more than to be caught off guard. Less.
Definitely. Yeah.
And on the flip side, sometimes it doesn't make it to the 1 year, and they're like, "Oh, they gave us 1 year."
Yeah, and
it was 36 months, So you
But
know,
she might have died of something else.
well, this is it. People don't realize that things can coexist.
Yeah. Okay, so here's another question. Why are they always late? Like you've booked in for 10 a.m. You're not going in at 10 a.m.
Yeah, you're not. And more annoyingly is when they're late, the doctor usually doesn't see them. If they're 10 minutes late, the doctor doesn't see them. But if they're even early, they still could be seen late in the doctor's register. Obviously, apologies to all you patients who are never seen on time. And that's again because of the system. One, the time slots allocated for the number of patients that come through to be able to keep the overall waiting list short.
Yeah.
The timing is usually quite short. It's usually like a 15-minute consultation, which means hello, hi, build a repertoire, how's everything, how's life.
But if you've seen your GP several times, you already have built that, right?
Built this.
So it's straight into it. Like, what are you here for today?
Today, exactly. But a lot of people don't come in like that. But remember, we're dealing with social creatures.
Yeah.
So some people will come in because they're not well. They've already come in feeling sorry for themselves as well. They're probably like, how are you? Oh, where do I start? I'm like, preferably the most recent.
The most recent.
Like, yeah. Or they come in with 500 problems.
Yeah,
They come with a list.
they can't do that either.
Yeah, they come up with a list of 10 things. And it's like, okay, look, I said, okay, so starting 10 months ago, there was this little niggle here that it came and it went and has never come back. What do you think that was?
In those time slots, but when I haven't, apologies to the people, I haven't had to book a GP appointment for some time, so I don't know what that looks like. But are you told that your time slot is 15 minutes?
Yes.
So you're told.
The patients are very well aware.
Oh, okay.
And
so if they do have a long list, could they book a double appointment?
They can book a double, but they don't want to.
Because do they have to pay a double? Okay.
So they don't want to. And again, it's about knowing, it's about that self-awareness. You know you have 15 minutes. So clearly, you should probably, not just think about the doctor, because the doctor can sit and chat with you. That's really not the issue.
Yeah.
But there's somebody after you.
Yeah.
So you should be that self-awareness that, oh, okay, I would love to sit here for an hour, but I know that there's also other people.
Yeah.
So is that care? Because a lot of people, again, as human beings, we tend to be selfish.
Yeah.
You know, you come in and you're like, this is my time. I'm going to do all my own thing. But you know very well that what your situation is. You still have to do your prescription. We still have to write your notes. We still have to do your blood. We need to do all of these things in that time slot. But a lot of times they don't care about whatever's happened. They're like, once I'm out here, I don't care. The other person can figure out what their own thing is. I don't care.
Yeah.
That if mine takes half an hour, mine takes half an hour. But you did book for 2 slots. You know?
Is it like a fat person not booking for 2 seats on the
No, plane. I'll be like, I don't care about the next person beside me because I'll speak over the person. So it's just awareness that, oh, look, I know it's so come in with top 2 things.
Yeah.
Or top 3 things. Be realistic. Think more about if there are hour slots, good, great. Everybody, the doctor will be happy, you'll be happy. We can all just have a good laugh, take our time, make tea, kumbaya, sing, go through your family album. But because it's so short, everything has to be, succinct. And again, it's an interaction. It's a social interaction. Yeah. So I can't be like,
so that's it. It might take a good 4 minutes to warm up.
Yeah. For you to really gather yourself and try to remember your symptoms, how it occurred. And so it is a pressure situation for the patient as well. Trying to even articulate. If you're talking to your best friend, you probably need to get it out quicker.
Yeah. So a tip to sick people in the future would be to, if they're booking in to see their GP, so it's not urgent, they just want to see their GP, go the information.
Yeah. Have a list of the most important, the most pertinent thing, and try to articulate yourself as best and as realistically as possible. Because again, going back to my doctor is bad, a lot of times people want to be heard and they want to be taken seriously. Yeah. And sometimes for a lot of people that means embellishment. I do love a good embellished outfit, but when you embellish your symptoms, it actually makes things worse because you're throwing them off.
Yeah.
Because you tell me, I have this stomach ache that's, 20 out of 10. And I'm like, do you have it right now? And you're like, yes. I'm like, it doesn't look like. So now I'm confused because I'm trying to figure, okay, where is it, And you're like, it's everywhere and it comes and like, I almost feel like I want to die. And that pain is happening right now.
They've been a bit dramatic.
Yeah. So that over dramatization, just because you really do not want to be dismissed or to be. So again, is anybody right or wrong? She's not wrong for trying to get heard. maybe her process of trying to do it to get heard was not the best. Again, we have 15 minutes to rewind all of this and reset it. And let's get realistic about it and let's try again. But the clock is ticking. And I know now that Sandra clearly is very upset by whatever this is. So I have to now take my time and say, okay, you're like, this is definitely going to be 15 minutes. But okay, so let's just start again. Okay.
So in the urgent care world, is the time slotting similar to a GP appointment?
No, that's the beauty. Ideally, you want to be able to see your patients within 20 minutes, but it can go for as long as required.
So in urgent care, the patient comes in and they are triaged.
They're triaged, so the nurse gets an idea of what they're presenting with.
What they're presenting.
So is this person really sick? Or is this person medium sick? Is this person less sick? And that's what the triaging is for. So even before the doctor picks it up, I have an idea how long this might take. And I can see the name beside you. The next person is just here because they want some antibiotics, a prescription. I'm like, okay, get that one out of the way so we can spend more time with Sandra. We can go through all her symptoms. And that's why they pay more. Because one, not only because it's urgent, because you want to have answers now, but also the time is variable. There's no rush. You can get a dressing done. You can get, if you've broken your leg or anything, you can get a cast. You can get all these things can be done through that because there's no actual fixed time. And that's why you're paying the big bucks to come to urgent care. That's generally what happens in those scenarios.
So with TUI, you have a mixture of the GP services and urgent care. So does every clinic in the Waikato have... So
most GPs might have a walk-in service, which acts like an urgent care. Obviously, what they're able to do is limited. So, they might not be able to do with acute injuries and stuff. But if you've had a cold and gotten a sore throat over the last 2 days, they just can't wait to book because the bookings are like 3 weeks ahead. Some GPs, especially rural ones, would have maybe 12 appointments for walk-in, so anybody can just walk in and get it.
Oh, that's good to know.
Yeah, but
because sometimes, when you do try and book in with your GP online,
it can be like 4, 5, 6 weeks,
or 5, 6.
Depending on how popular the GP is. So there are people a lot of times in your GP clinic. You have the GP allocated to you. You don't necessarily
have to see that.
You don't have to see that particular person. If you have a very complex history and a great relationship, you may say, actually, do you know what? It's easier.
So that's changed over the years, because I feel like when I was younger, we always went to that same GP.
And that used to be the case where we realized that a lot of times, for example, that GP is very popular, let's say with kids and stuff. So all the kids are booked into him. So he might have a waiting time now of 8 weeks because it's always fully booked. While there's another GP who doesn't necessarily see kids, maybe sees the older people, and generally with the older patients, they might already know what they want. A lot of their things are routine. There's not a lot of surprises. It's like, oh, my cholesterol tablets have run out. Can I come in and just say, just say hi, check my hair, here's some baking, and they're in and out. So those kind of GPs may have a lot of open slots. A lot of times you don't want to wait for your own particular GP. You can always go into that one, especially if you know what you're coming in for. If you're like, oh, my son has a sore throat, I don't necessarily need to wait and see my GP. If my child had a chronic long-term condition that my GP is aware of, we've tried this and tried that, and I tried this. The system. So it's easier to follow up that way. But if it's something isolated, like, a cough, everybody knows, you can just go and book that one. So that's usually why some people have a very, very long waiting list and some don't. And there's just not a lot of GPs. The numbers are dropping, plummeting by the minute. Those are usually the reasons why, there's this long waiting times, and you don't necessarily, again, have to see a GP. And if you don't want to see the GP in that practice because you don't like their face, you have the option of urgent care. That's where urgent care comes in. But ideally, if you can go into your GP, that's obviously cheaper and it's easier for us, again, trying to build the social bond, which most people are used to now at this point because they've all gone to an A&E at some stage in their lives, so you know how the drill is.
Oh no, this has been cute. I know there's probably more questions from
I'm sure there will be.
From the people out there, our listeners, our fans.
Well, after this, I don't know if they're going to still be fans. They're like, those damn medics.
But if you've got any questions that we may not have covered in today's episode, feel free to flick them through. Send us a DM.
And or you can always just pop into TUI Medical if you want to see me in all my glory. I'm just kidding. Or if you're looking for, we have quite great GPs, I have to say. I'm obviously not just being biased here, but we do have quite good.
You do have a good team.
Yeah, GP.
Very
So we're moving on to the fun segment. I'm glad I'm off the hot seat for now.
It was the hot seat.
It was
How
very
did you
hot.
feel?
It was sizzling. You really embodied the patient. I was actually quite intimidated. I was like, why does she do this?
It's because I'm a doctor in the making, guys.
You definitely are, if not already made. So I'm going to give you some questions.
Okay.
Some New Zealand and worldwide stats.
Oh my God, I love a stat.
And see if you... these are just general questions regarding, the healthcare system and how broken the whole thing is. So our first question, and this segment's got, let me fix it! Let me fix it! So our first question, I'll give you the question, I'll give you options.
Okay, cool.
Okay? So the first question is, what percentage of Kiwis wait more than 2 weeks for a GP appointment? Is it more than 30%, more than 60%, or more than 80%?
60.
B. So
am I right?
no. So it's actually 30%. So it's actually quite low.
That's not bad then. Here I was thinking it was really shit.
Yeah. Comparatively in Australia, it'll be about 40% of people wait for GPs more than longer than 2 weeks. In Ireland and the UK, it's 70 to 80%. So you would probably not 80% get a GP. In the US, it's about 10 to 20%. So they're quite good.
Because they have a lot.
They have more
Yeah.
resources.
Yeah.
And in Canada, it's about the same 10 to 15% of people would wait.
You have to have your healthcare medical insurance,
Insurance
right?
and stuff. Yeah. So even
America.
kind of factoring all that in with access and everything, they still, the average time for, the longest average is in the UK. So you would definitely, 80% chance in Ireland not see a GP in 2 weeks.
That's terrible.
Yeah. So New Zealand is not
We're
that bad.
not so bad, guys.
No.
So everybody relax.
Let's just calm our tits. Question number 2.
Yeah.
Which of these do you think is the lead cause of long waiting times in NZI?
Okay.
Is it A, patient preference for specific GPs? B, shortages of GPs? Or C, the increased demand due to the increased population?
I feel like it's a mixture of B and C. Yeah. Am I right?
Yes.
Am I?
You are very right. So it is a mixture. It is a mixture of B and C.
Yeah.
Yeah. And generally, in most parts of the world, that would be the main one. But the main healthcare system issues would be understaffing and chronic shortages.
Yeah. And then just a lot of sick people.
A lot of sick people. A lot of bed
Diseases
blocking.
and
same thing goes in Australia as well. They say the biggest cause would be overwhelming bed blocking. So people being stuck in the hospitals because there's just not enough staff to either get them into the wards or get them off the wards. And in the UK, they say this imbalance between high patient demand and capacity. So a lot of the world is generally demand and the population.
supply.
So well done, you. Your last question. You ready?
Yeah.
So what percentage of doctors in New Zealand are internationally trained doctors? So how many doctors are actually Kiwis?
Okay, I like this one.
A, is it 25%?
No.
B, is it 40%? Or C, is it 60%?
60.
The answer is 40.
Oh.
So in New Zealand, 43 to 44% of the doctors are international.
Wow.
In
I thought it would be higher.
I thought so too. In Australia, 36% are international. In Ireland, roughly the same, 40 to 43% are international doctors. In the UK, 42%. In the US, 25%
Oh,
are
wow.
international. Most of them are locally grown. And in Canada, about 30 to 33%. So New
Interesting.
Zealand is still the highest globally.
No, it's 'cause- right, so our kids, they go to university, they study
Their
doctorism.
medicine.
But yeah.
even at that, we're still, like, Australia still has, they're not too far behind. They're about 36.5% of their doctors are international.
Interesting.
But New Zealand has up to 44%. So it's the highest, one of the highest globally. And I suppose it's because of the size of the country. So obviously the number of doctors being pumped out, even if they were not leaving, wouldn't be as high as the growth rate of the population. So there was always going to be that demand and supply imbalance, as it were.
Yeah.
But obviously it's now even more strained. And then that the doctors are leaving, whereas the population is not reducing.
No.
So that's probably it. But yeah, that was a nice, quick, cute one. You did really good.
I'm a doctor.
I think you just heard me bitching way too much. But yeah, that was a cute segment. So
I want to finish off the fun segment with just what would be your cutest, quirkiest advice that you could throw out there right now? I'm putting you on the spot.
Love being on the spot.
With regards to anything doctorism, like just...
Okay, sure. So I think it's just kindness.
Yeah.
It's just everybody just try to be kind and try to be thoughtful and aware of your fellow person. So be it the doctors, be it more kind and just empathetic. If we're more empathetic to each other, we'll be able to help each other out better.
Yeah.
Try and put yourself in other people's shoes. Put yourself in the shoes of the person sitting next to you in the waiting room. Put yourself in the shoes of the mom who has 10 kids there screaming, but you're next.
Yeah.
But if she can go before you, see if you can, what ways you can help.
Yeah.
Doctors to be, more empathetic towards it. I know that's the day in, day out. But if we can all just be that little bit more aware, I'm very cautious of that, of being empathetic, even more than our natural capabilities, that will go a long way, because the system is broken for everybody and broken everywhere, as we can see. So it's just that little kindness to other human beings, that we're all in it. There's nobody who is not feeling it to some degree, be it on the professional side or be it from the patient side. Probably the patients more so, because, they're sick and they need the help. So it's just so everybody just be that little bit, more kinder.
Cute, I love it.
Yeah, that would be my little...
It's a nice little hot tip there.
Hot tip, guys.
From Dr. Tanya.
Don't be a bitch.
Don't be.
You would stay away, but anyways, we would bring this session to a quick close.
We just want to say a big thank you to who?
Thank you to Aotearoa and all the GP clinics throughout the Waikato and in New Zealand for doing the work that they do. Nurses, all allied health professionals, everyone in the medical field really, that just try to help improve the quality of life for all of us in Aotearoa. I would also want to thank you guys for joining us today. I'd like to thank Hoana for being such a good for being a good patient today. As we discuss this topic, and obviously, like we said, if you have any questions, please fire them through.
Don't forget to like and subscribe. The link below. Obviously, we are here on YouTube. You can see us also on Instagram, TikTok, Facebook, and Spotify.
If you don't want to see our faces.
If you don't want to see our faces.
But I don't know why you wouldn't. And obviously, if you like this episode or something like this, you can tune into one of our other episodes in season 1, episode 2. Titled Ask the Doc.
That was when we were super fresh.
So do not judge us on that one.
We will never remove our old episodes though, because you've got to come from somewhere.
This is it. So the journey is upwards, at least. That's what's important. But
thank you once again. We really appreciate you joining us, and we will see you next time.
Bye.